in Arkham Learning or any website, recommended website and a trusted website. So, for example, if you write erythema nodosum differential diagnosis, is one of them on the disease. So once you see it in the scenario and they ask you about the diagnosis, you can choose any one of the differential diagnoses. Here, ulcerative colitis. So if you find bioderma gangrenosum, erythema nodosum. So for example, if you find ulcers and erythema nodosum, so it's ulcerative colitis. Of course, liver disease here, pruritus, spider nevi, erythema. Malignancy, so you will find acanthosis nigricans, it's very common, and it means GI malignancy. Here, alopecia may be hyper, maybe hypothyroidism. So, what are the features here, guys? What is the description in this image? What do you think?
Hyperpigmentation.
Hyperpigmentation and?
Vitiligo.
Yeah, so the opposite here. Okay, here hyperpigmentation and here vitiligo. So you can think about adolescence. Maybe you will do laboratory. Maybe it's normal, so it's not adolescent disease. But if you will do lab and check the result going with adolescent disease, so you can confirm now. If you find it's not adolescent, refer to dermatologist. But if you find it's confirming adolescent disease, you refer to internal medicine. So you are emergency physician. You are the first line with any patient. Here, how to confirm it's adolescent disease, guys? 3 up and 3 down. What do you think?
Hypotension, hypoglycemia,
hyponatremia,
Excellent.
hyperkalemia, hypercalcemia.
Excellent. Okay. So 3 hyper, it means hyperkalemia, and it's dangerous. Hypercalcemia, dangerous. And also hyperpigmentation, it's not dangerous, but it's a diagnostic. And regarding hypo, so hyponatremia, dangerous. Hypoglycemia, dangerous. And hypotension, dangerous. So additional crisis, we are talking about the crisis. But the disease, no worries regarding the disease. Okay, we are talking about the crisis. So what is the treatment for additional crisis?
Hydrocortisone.
steroid injection.
So hydrocortisone 100 milligrams and IV resuscitation. Excellent.
Yes.
Yeah. So IV resuscitation here, it means normal saline and dextrose infusion as well. And here some people will say, why I will not correct hyperkalemia? Why I will not correct hypercalcemia? Why I will not correct hypoglycemia? So if you will correct the underlying cause, everything will be corrected. So the underlying cause here is steroid deficiency. So if you will give hydrocortisone, everything will be normal. Okay? And here, pigmentation, striae, hirsutism, acne. So you can diagnose Cushing disease until proven otherwise. And here, as you see, maybe xanthoma, maybe shiny yellowish flakes on the skin, maybe granuloma. Okay, so it's a palpable ring lesion on hands, face, or feet. So you can expect diabetes mellitus, and of course, you will check blood sugar, it will be high. What is that, guys?
Xanthoma.
Xanthoma, okay. And here in the skin, maybe, as you see, elbow, and maybe on the face, like that. Okay. So it's a hyperlipidemia. And this erythema nodosum, it doesn't mean Crohn's disease. Okay. So it's, for example, Crohn's disease. We have many causes of erythema nodosum, but one of them Crohn's disease. We are giving just example. Ulcerative colitis, so it's a very important topic. It can be a question in the exam. Okay, so it can be question in SPA, and it can be question also in OSCE. So they can give you a question in SPA as a single best answer, and it can be situation in OSCE. They will give you patient with rashes and ulcers in the leg, for example, and the patient has abdominal pain, maybe blood diarrhea. So you can, this one, as you see here, it's called bioderma gangrenosum. And of course, erythema nodosum, as we showed you in the previous slide. So you can diagnose ulcerative colitis. Of course, liver disease, it's very common, and all people familiar with that. So spider nevi, erythema, pruritus. And this one in the axilla and in the neck. So you can diagnose acanthosis nigricans. It's a feature of malignancy. Alopecia, as we said, may be hyper or hypothyroidism. So if you find acanthosis nigricans, if they mentioned in the scenario or they show you image, so you have to put differential diagnosis in your mind. So it's a brownish black, poorly defined hyperpigmentation of the skin in the axilla, maybe groin, maybe neck, maybe forehead. So any skin in the groin or neck or axilla or forehead. Common in African American ethnicity, associated with numerous conditions. One of them malignancy, especially gastric carcinoma, lymphoma. Also maybe acromegaly, maybe Cushing syndrome, maybe diabetes mellitus, maybe polycystic ovarian syndrome if female, maybe obesity. If they give you any option in the question like diabetes insipidus, don't choose. Here also, if the patient, if you see this rashes in real practice or in the exam, and you find the patient is IV drug user, or the patient has a history, past history of HIV, or he has history of transplant, whatever, any organ transplant, so you can think about Kaposi sarcoma. Okay, so it's a connective tissue malignancy caused by human herpes virus 8. You have to be familiar with the number. Sometimes they will give you a human herpes virus 8, 10, or whatever, so you can choose 8. So immunocompromised patient, whatever, HIV and transplant patients. So cutaneous lesions begin as red-purple macules. We will discuss now about macules and papules and pustules and other rashes. Rapidly progress to become papules and nodules. So they can occur anywhere, but are most seen in the lower limbs, back, face, mouth, genital. So when you are studying, you can expect to see that in the scenario, or they will give you an image with lower limbs or back or face or mouth or genital. Systemic lupus erythematosus, so you can find in the exam like face. So it's a multi-system connective tissue disorder characterized by skin rashes, arthralgia, antibodies against double-strand DNA. Most commonly affects young women. So if you find the patient female, so it's likely. The male ratio, female and male ratio, it's 10:1. So most likely in the exams, they will give you female. More common in West Indian population. So you might find Indian patient in the scenario. This patient has classic butterfly rash, this one. So erythema over the bridge of the nose and the cheeks. Exacerbated by sun exposure and can precede the onset of SLE. Joint disease, the patient has arthralgia. So joint disease here can affect both whatever large or small joints. So maybe knee, maybe proximal interphalangeal, maybe wrist with the carpophalangeal joints. So this one. Erythema multiforme, we are talking about number 2 in dermatological presentation, erythema multiforme. So target lesion. Target lesion here, you have to understand 3 rashes. Number 1, target lesion. Number 2 is Stevens-Johnson syndrome. Number 3, toxic syndrome. So we will discuss 3. Both of them start by target lesion. It means erythema multiforme. So this is the first presentation, early presentation. Late presentation, it will be Stevens-Johnson syndrome. And if the body surface area big, it will be toxic syndrome. We will discuss that later. So here, once you see target lesion, I want you, when you are studying, use Google. Always use Google. Don't study without Google. Always open, okay, in the background. Once you are studying, for example, erythema multiforme, you can search for erythema multiforme in Google, in images, okay? Why? Because in the exams, they can give you any image from Google. So maybe you have image like that, but in the exam, different image, okay? So you have to be familiar with different images when you are studying. For example, X-ray for any fracture, you have to check, for example, Colles fracture in Google. They will give you different shapes and the different fractures in Colles. Smith fracture, you have to check in Google, Smith fracture, and so on. So don't study without Google, okay? Target lesion, so they can ask you what is the lesion here, or what is the description, so it's a target lesion. They can ask you what is the diagnosis, so you can say erythema multiforme. They can ask you what is the most common cause, so it will be herpes simplex virus. And here herpes simplex virus, as you know, it's type 1 and type 2. But in this erythema multiforme, type 1 is more common, okay? Many other infections or infectious causes of erythema multiforme. So as we said, the most common or the first commonest cause is herpes simplex virus, type 1. The second one, mycoplasma pneumonia. You have to be familiar with the commonest and the second commonest cause, okay? You have other causes like TB, Neisseria meningitidis, staph, salmonella, herpes zoster, adenovirus, hepatitis virus, HIV, cytomegalovirus. But again, the most common herpes simplex virus type 1. Here another image in the hand, so they can give you this image in the exam. And this is another image, okay? So target lesion means outer layer and inner layer and center. So the outer layer, it's red and it's deep color, and the inner layer, it's bright, and the inner layer, the center, as you see here. So it's called target lesion. And another image. So if you search when you are studying for images, it will give you clear idea about many shapes and many images of different topics. Erythema, another erythema. erythema AB. So here, this patient sometimes is using hot water because of pain. So those people, they are using hot water. That's why it's called hot water bottle rash. So this rashes, this one or this one, okay, this one in the abdomen and this one in the hands, because people, they are using hot water. Why? Skin rash here caused by long-term exposure to heat, seen in patients with chronic pain. That's why they are using hot water. Okay, so if you find in the scenario the patient has chronic pain and they have this image or this image and the rashes of hyperpigmentation and also maybe hands, maybe abdomen, so you can choose erythema AB. Acute pustular psoriasis. So it's a generalized pustular psoriasis. It's inflammatory skin disease. Generalized here, from the name, it's general. Occur with or without prior history of psoriasis. So the patient, maybe he has psoriasis, maybe not. Okay. Possible triggers. So sudden withdrawal of corticosteroids. So in the scenario, they will mention the patient stopped steroids. He was on steroid and the patient stopped medicine, for example, 1 week or 2 weeks. Also maybe drugs, the patient on lithium, aspirin, indomethacin or beta blocker. So it's a different cause. Maybe infection, maybe the patient female and pregnant. So always don't depend on the images. You have to depend on the images and the scenario. If you are studying, you are formulating scenario, you are formulating presentation. It's not about memorization. You are expecting scenario and you are expecting question, you are expecting answer, okay? The condition is potential life-threatening, okay? So the patient has fever, systemic upset, widespread erythema, because it's generalized. Pustular here, it means like pus. We will discuss that now. The skin is often very red and hot to touch, numerous small yellow pustules, and later it will be large patches of pus. Arthralgia may occur. The management here, take baseline bloods. Baseline here, it means hematology, biochemistry, blood gases, blood culture. So it means routine investigations. IV fluids, 1 liter, 0.9% saline. IV paracetamol as analgesic and antipyretic. IV antibiotic because of pustules, pus, as you see here. So IV antibiotic here, benzyl penicillin, 1.2 gram, and flucloxacillin, 1 gram. Here, if you are studying, you can expect this point as a question. So if they give you this one and they give this information, so they can ask you about the treatment. And sometimes they are giving similar options. For example, IV antibiotic penicillin 1.2. Sometimes they can give you a tablet, benzyl penicillin 1.2 gram tablet. Sometimes they can give you ointment. So similar options in the exam. That's why make difficult options. Okay. So it's not about to study the name only. You have to study the name, the route, the dose, and so on. Okay. Sometimes you have to mention both. If they mention benzyl penicillin and flucloxacillin, so you have to choose both. If you find one option for both and one option for only one, so you have to choose both, and so on. This is how to study. Don't study only the name. Urinary catheter, because you will give fluid. Any fluid treatment or any fluid management, so you have to insert urinary catheter and monitor urine output. Refer to medical team on call and arrange urgent dermatology review. So here, refer means now, and arrange it means later, or urgent dermatology review. Okay. Presentation number 2, so we will discuss also pemphigus. You have to be familiar with the most common pemphigus, so vulgaris and pleusis. So the most common here is vulgaris. So pemphigus here, it means autoimmune disorders in which there is blistering of the skin and or mucosal surfaces, triggered by maybe drugs, maybe burns, maybe stress, maybe vaccinations, tumors, radiation. So drugs here like penicillamine, captopril, rifampicin. 2 major variants of pemphigus, so vulgaris and pleuris. There's another categories like herpetiformis, IgA pemphigus, paraneoplastic, IgG, IgA pemphigus, but they are rare forms. So the most common here is vulgaris, it's 70%, and the age 40 and 60. So if you find in the scenario 40 and 60, so it can support your diagnosis. Treatment. In your study, guys, always study how to diagnose and also causes and how to treat. Okay, the investigation, causes, how to diagnose, how to treat, and so on. So treatment here, you have to reduce pain and symptoms, preventing complication like infection. High dose corticosteroid, because we said it's autoimmune disorder. So high dose corticosteroid, the first line. If you find this option, you can choose prednisolone 60 milligram only. Steroid should not be tapered until most lesions have healed. So don't start until 80% have healed to reduce the chance of subsequent flare in disease activity. Plasmapheresis can be used in very severe cases. So if they said in the scenario, the case is severe and you find the option of plasmapheresis, you can choose. Again, in the exam, you will find similar options. So you have to take care about when to choose this answer, when to choose this answer, and so on. Okay, it's not about treatment you will memorize one treatment. No, you have to understand when to choose this, when to choose this, when to choose this. Okay. So you have to be familiar with vulgaris and bullous. Okay. Bullous, from the name, you will find the bulla. Okay. So here, this is the appearance and the age. So this one younger, this one older. Regarding mucous membrane involvement, this one you will find in mucous membrane. Mucous membrane here, it means like mouth, like nose, and so on. Okay. So here, yes, this one rare, not involvement regarding mucous membrane. Autoantibodies in vulgaris, so it's against desmoglein 3, and in bullous against imidazmozones. Blister location, this one superficial, this one deep. Quality, so this one flaccid and rupture easily regarding the blister. As you see here, all blisters is already ruptured. Okay, so both of them with blister, but this one ruptured, this one still. Okay, and regarding the bullous, so it's tense and firm. That's why the nucleoside sign here it's positive, here it's negative. The prognosis here, this one poor, means it's dangerous, this one. Okay. Another comparison between them. So again, the age here, middle-aged people, as we said, 40 to 60, and this one, elderly people, 80. The oral involvement, as we said, common here, rare, and the blister, again, we are just repeating. So it's a large, flaccid, and painful. Here, large and dense. Here, blister content, fluid filled. This one, hemorrhagic. Areas commonly affected. This one, initially face, after that scalp, then spread to the chest and back. This one, bullous in the upper arm, thigh, and the skin flexures. As we said before, blue sky sign, here positive, here negative. So if they mention in the scenario, blue sky sign positive, so it's supporting vulgaris. As we said, this one rare, but poor prognosis. Skin biopsy here, you will find intraepidermal deposition of IgG between cells throughout the epidermis, and the bullous band of IgG and or C3 at the dermo-epidermal junction. So this one, which type, guys?
bullous pemphigus.
Bullous pemphigus.
Okay. Here, regarding rashes, dermatological presentation number 2. So you have to be familiar with Lofgren syndrome. It can be a question in the exam. So they can give you whatever erythema nodosum or bilateral hilar lymphadenopathy, as you see here in the X-ray. And also it can be both. They can give you both images, and it can be in the scenario. They can mention in the scenario the patient has bilateral hilar lymphadenopathy on chest X-ray, and they will not give you X-ray. This is how to study. So here the rash is erythema nodosum, and Lofgren syndrome most commonly affect women. So you will find in the scenario, for example, 30 or 35 or 40 lady, most common in patient Nordic and Irish descent. For example, you will mention the country. So if the triad here for Lofgren syndrome, bilateral hilar lymphadenopathy, erythema nodosum, and they will mention the patient has arthralgia, especially in the ankle. They can mention that in the scenario. So if they ask about the diagnosis, if you find Lofgren syndrome, you can choose. If you find the sarcoidosis, you can choose any of them, okay? Because it's a subtype of sarcoidosis. Erythema nodosum, you have to be familiar with the differential diagnosis, and you have to understand what is erythema nodosum. So it's a delayed type hypersensitivity reaction. As we said in the start, it can happen with many differential diagnoses, okay? So erythematous, tender nodules, where on the chin, as you see here. The etiology here can be infectious, can be drugs, and it can be chronic disease. So infectious, it can happen with strep or mycoplasma or TB or HCV or Yersinia. Drugs, if the patient in the scenario is taking sulfonamide, penicillin, phenytoin, okay? Chronic disease like sarcoidosis, lymphoma, lupus, inflammatory bowel disease. So epidemiology, more common in women, 2nd to 4th decade. So as we said, it's a tender erythematous nodules on bilateral chins, bilateral. So both legs. Possible infectious prodrome. Nodule typically resolve without scarring after 8 weeks. So after 8 weeks, you will not find any scars. Management, as we said, after 8 weeks, so it's a self-limiting. You can give non-steroidal because it's a tender. Okay, tender. Potassium iodide, corticosteroid. This second line, but first line will be non-steroidal anti-inflammatory. Another dermatological case. So anthrax. Anthrax here, it was common in 2009 and 10. It was very common at that time, but now it's not anymore. It was among heroin users in Scotland. Okay, as you see, this one, it's very easy to diagnose in the exam. Okay, they make studies. They found it's most common in heroin user in Scotland. The causative organism here, any dermatological or any case in the exam, they can ask you about the causative organ. That's why when you are studying, you have to be familiar with the causative organism. So here, Bacterium Bacillus anthracis, and spread by spores. Also, the mode of infection, it's very important because they said they will ask you about the basic sciences. Now we are talking about the basic sciences, okay, which are highly resistant and they can survive almost indefinitely. Continuous anthrax occurs when these spores enter through skin breaks. So the mode of infection by spores and through skin breaks. The infection starts between 2 and 7 days after exposure. So the incubation period, the patient now injured, so he will get symptoms after 2 to 7 days incubation period. Usually begins as raised or swollen, itchy, red pump, similar to an insecticide. So they can give you the image or they can give you this information. Okay. Within a couple of days, ulcer will form black center. So they can mention black center or scar. So you can diagnose. The lesions are often painless. It can be in the scenario. They can mention in the scenario, it's painless, no pain. Patient may also exhibit signs of constitutional abscess. So they can mention in the scenario, the patient has constitutional symptoms. They can say the patient has fever, headache, general malaise. What about the treatment? So anthrax can be treated effectively with antibiotic if recognized early enough. It generally requires high dose IV fluoroquinolones like sevofloxacin, macrolides like clarithromycin, doxycycline, benzyl penicillin. So you can use any option, high dose. Meningococcal septicemia, it's very common in the exam, whatever SPA or OSCE exam. Any exam for real college, very common. So in a child with non-blanching rash, so if you find in the scenario non-blanching rash, so you can choose meningococcal septicemia. So here you will find in the scenario ill-looking child. You will find in the scenario maybe lesions larger than 2 millimeters in diameter, or they can give you image with lesions larger than 2 millimeters in diameter. So it's called berbera. We will discuss later the difference between berbera and petechia and ecchymosis. So which is smaller guys, petechia or berbera?
Petechia.
Okay. So petechia, after that berbera, after that ecchymosis. Capillary fill time of 3. So any capillary fill time of 3 means the patient has shock. So if you find in the scenario in the exam, these features, you can choose the diagnosis. Or they can give you the diagnosis. They can ask you by opposite way. When you are studying, you have to expect the question by opposite way. For example, they can say, the patient has non-blanching rash. Which of the following features recommend or supporting your diagnosis? Okay, so if you find any of them, you can choose. And also neck stiffness. The most organism here, Neisseria meningitis, okay, group B. So you have to put in your mind, okay, it can be an option in the exam. If signs of septic shock, if you find in the scenario, okay, so already you diagnosed meningococcal septicemia and you find CRT more than 3, or you find the blood pressure is showing hypotension according to the age. You have to be familiar with the blood pressure according to the age. So here, the treatment will be single dose of benzyl penicillin without delay. You have to be familiar with the dose according to the age. So infant here, it means less than 1 year. So you can give IM or IV penicillin 300 milligram. So they can give you any option, 300, 600, 1.2. So you have to check the age. Infant, you can choose 300. Children 1 to 9 years in the scenario, so you can choose 600. And the children, adults 10 years or older, so you can choose 1.2 gram. Here, early stage, and this is when it's the final stage. Okay. Hand, foot, and mouth disease. From the name, it means you can find it in the hand, you can find it in the foot, you can find it in the mouth. Okay. So it's a viral syndrome with distinct exenzyme, enzyme. What is the difference, guys, between exenzyme and enzyme?
Skin and mucous membrane.
Mucous membrane.
Exenzyme is external and enzyme is internal.
Excellent, excellent. Okay. So here, from the name, we are talking about hand, foot, it will be exenzyme because it's skin, and the mouth, it will be enzyme because it's mucous membrane. So it's called with a distinct exenzyme enzyme. And again, it's a viral syndrome. It means the cause here, exactly A16 virus. Incubation period of hand, foot, mouth disease, 3 to 5 days. Droplet spread, they can ask you regarding basic sciences. So these are basic sciences. It is often preceded by prodromal illness, followed by sore throats and mouth ulcers. Most commonly affected children less than 10 years. So you will find this a scenario, whatever, 5 years, 4 years, 3 years, until 10 years. Most will also develop spots on the hands and feet from the knee. So the treatment here, mainly supportive. So supportive here, it's not specific treatment. For example, the patient has fever, you will give antibiotic. Adequate hydration, you will give fluid. Okay. Why? Because the patient maybe has loss of appetite because of mouth ulcers. That's why he doesn't want to eat. So again, from the name, hand, foot, and mouth. Okay, so we finished the presentations. We will discuss first condition, common childhood exenzymes. From the name, exenzymes, it means skin or mucous membrane.
Skin.
Skin.
Okay. Yeah, it's a very important question in the exam. They can give you how many questions, guys, regarding pediatric?
25.
20.
25 تقريبا.
So they can give you from any topic more than one question, more than two, more than three. It's up to them. Okay. So you have to study pediatric. Well, here regarding the common childhood exenzymes, there is 3 main types of rashes. The first is potentially worrying. For example, you will find petechia, purpura, like for example, meningococcal septicemia. And the second one, it's named rashes. Once you see the rash, you will diagnose. For example, if you see the rashes for chickenpox, it will be easy for you, chickenpox or measles. You find the rashes for initial and purpura, you will diagnose. Erythema multiforme, target lesion. So each of them specific for special diagnosis. Idiopathic thrombocytopenic purpura, eczema, psoriasis, and so on. And the third type, everything else, rather than petechia purpura, rather than named rashes. So it's called everything else. So it's a non-descript, non-specific features. You cannot diagnose. Okay. So here, sometimes it's erythema infectiosum, sometimes it's Rosella exansum sabitum, for example. And most rashes for children, they can present with febrile illness and rashes. So most rashes with febrile illness. 70% virus, 70% of rashes virus, such as Coxsackie or ecovirus or enterovirus. The rest will be bacterial infection, like for example, strep or staph, or maybe mycoplasma. Okay, sometimes also drug-related, or maybe Kawasaki disease. So the prodromal symptoms, prodromal here, it means the patient has, before rashes, he has irritability, loss of appetite, fever, malaise, headache. So for example, the patient has 1 day or 2 days or 3 days with these features. After that, he has rashes. So it's called prodromal symptoms: irritability, loss of appetite, fever, malaise, headache. Some illnesses are associated with typical rash. So once you see the typical rash, you will diagnose. For example, as we said, but once you see the rash in the buttocks or in the posterior surface of legs, you can diagnose hencholamper. In other cases, the clinical... Guys, can you hear me clearly now?
Yes,
Yeah, we get that.
Yes, sir.
Okay.
Not clear.
If clear with some people, it means the other people from their side. Okay. So in other cases, the clinical features may not be specific enough. Okay. You have to be familiar with exenzymes and enanthemes. So as we said, X means external, N means internal. So here for skin, and this one for mucous membrane. The most common childhood exenzymes. So you talk about first disease, second disease, third disease, fifth disease, and sixth disease. They can ask you in any of them in the exam. So you have to study them very well. First disease. So we are talking about rubella, measles, and you have to be familiar with different names, because sometimes in the exams they can give you option in the scenario, in the question. For example, rubella, and you studied as first disease. You have to be familiar with different names because you can choose according to the options. Okay, so here first disease equal rubella equal measles. Second disease, scarlet fever or scarlet. Anyway, it's not common, so scarlet fever. Third disease, rubella or German measles. 3-day measles, it's not common. Fifth disease, so erythema infectiosa. Sixth disease, so exenzyme sabitum or Rhizolia infantum. And you have to be familiar with the causative organism. So rubella or measles, paramyxovirus. Scarlet fever, it's a common question in the exam. So streptococcus, they can ask you clearly which is the causative organism or what is the causative organism, and they can give you options. You can choose streptococcus. Rubella from the name, so it's rubella virus. Or maybe they will give you German measles, so you can choose rubella virus. Fifth disease or erythema infectiosum, so parvovirus B19, sorry. And also you have to be familiar with the number. Sometimes they can give you parvovirus B19, B16, and so on. So you have to be familiar with the exact number. Sixth disease, so exenzyme sabitum or Rhizolia infantum. So it's a human herpes virus 6B or human herpes virus 7. And also again, you have to be familiar with the exact number. When assessing a child with rash, even not a child, so whatever child or adult, when you are assessing any rash in general, you have to check the distribution, you have to check the color, the size. Is it blanching or non-blanching? Is it palpable or not? Any petechia or not? Okay. So here, as we said, petechia, very small, 1 or 2 millimeter. If more than 2 millimeter, it means we are talking about purpura. So it's more or equal than 3 millimeter. Ecchymosis, it means more than 1 to 2 centimeters. So here the distribution. You have to check this rash. Even in the scenario, you have to check, is it central or peripheral? Okay. Dermatomal or not? Dermatomal like what, guys?
herpes,
Herpes zoster,
Shingles.
shingles.
shingles,
Shingles.
It's a following dermatome. Okay.
Yeah.
Extensor surface. So it's in the extensor or flexors. You have to be familiar with that. Okay. Mucosal involvement. So it's involving mouth, nose, or eyes. Okay. And again, color, size, branching or not, palpability, and if there is petechiae or not. Here you have to be familiar with the description. Is it macule, babule, nodule, plaque, pustule, vesicle, bulla? It's very easy to differentiate between them. So macule here, it means there is no elevation, no skin elevation or depression. Means not elevated or not depressed. But here is the difference only area of a change in normal color. So maybe red, but no elevation, no pus, nothing, no depression, means no ulcer. Okay, so it's called macule. So only change in the color. After that, babule. So babule here, it means raised lesion, but a small size. So 0.5 up to 1 centimeter. So it's called babule. After that, nodule. So nodule here, it's deeper in the dermal or subcutaneous tissue and palpable. So the difference between also nodule and the babule, it's not about the size. It's deeper and maybe the size is bigger, but here it's palpable as well. Okay. Plaque, it means large area in relation to its height. So it's raised, but the width more than the height. Pustule from the name pus. So elevation of skin, but here containing brilliant fluid of variable characters. Maybe white fluid, maybe yellow, maybe green, maybe hemorrhagic. So don't expect only yellow or green. So pustule here, whatever the fluid, whatever the color, whatever the character. So any fluid, it means pustule. Vesicle here, it's elevated fluid containing lesion less than 0.5 to 1 centimeter in its greatest diameter. Bulla, so it's the same as vesicle, except the lesion more than 0.5 centimeter in its greatest diameter. So from the name bulla. So what is this, guys?
Macule.
So it's a change in
Color.
elevation. What about this?
Babule.
Papule.
Nodule.
Nodule. Nadib.
Nodule.
This one?
nodule,
Nodule.
Nodule.
So is this one nodule or babule?
Babule.
papule,
Papules.
Okay. And what about this?
Pustule.
Tube.
Okay. What about this?
Vesicle. Bulla.
Okay. So here we are studying the description because it will help you to diagnose. So if you find, you have three description: maculopapular and diffuse erythema with disformation, and also vesiculobullous or pustular eruption. 3 slides, it will give you explanation for most of the rashes. Okay, we will start by the first one, maculopapular eruptions. So it means maculate means
Change color.
Non-race.
Non-changing color.
Color
So-
change of skin.
change in the color, but no elevation, no depression. And the other areas in the same person, in the same patient, with babule. Okay, so you can find the macule and the babule. That's why it's called maculopapular eruptions. So common or most seen in viral illness and immune-mediated illness. So here you have to expect measles, you have to expect rubella, erythema infectiosa, slapped cheek, so it's red cheek, exanthum sabitum, so it's rosella, Lyme disease, triasis, drug-related eruption, erythema macrophago. So if you find in the option scarlet fever, you will choose in the exam.
No.
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 This is how to study, guys. So if you find in the scenario maculopapular eruption, and we give you options for measles and scarlet fever, don't choose scarlet fever. You can choose measles. Okay. And also regarding viral, it's related to vaccination. They will mention the patient is not immunized. Okay, so it will support your diagnosis. Okay, so any scenario or any case in the exam, they will give you clues. So from this clue, you can choose your answer. Here, diffuse erythema with discomation. So they can mention in the scenario with diffuse erythema, they can mention discomation. So the patient has fever, non-specific symptoms. And here you have to think about maybe scarlet fever, maybe toxic shock syndrome, maybe staphylococcal scalded skin syndrome, maybe Kawasaki disease. If you find discomation in the scenario, it's supporting any of them. Okay. And here sometimes with scarlet fever, they will say, they will not mention regarding immunization. If they will mention, they will say the patient immunized, has his immunization up to date. It means it's not viral. Okay. Or maybe they will say the patient already take antibiotic, but it's not, it's worsening. So it's supporting his diagnosis of scarlet fever. If they mention, or you can see in the image, vesicrobullous or pustular eruption, so you can think about varicella zoster, you can think about gonococcinea, Coxsackie virus, herpes zoster, staphylococcal bacterium. This from Arkham Learning website. If you will search in Arkham Learning website, if you will write, it's free. Again, guys, regarding Arkham Learning, you will find more than 60% or more than 70% free topics and cases. Okay, so it doesn't mean you have to subscribe or something like that. But it's better to subscribe. It will give you option for SPA questions and different cases. It's not free. But anyway, if you don't want to subscribe, it can give you more than 60% or more than 70% free. So you can search in Arkham Learning regarding childhood exancine. They can give you measles, scarlet fever, rubella, erythema infectiosum, and all these slides. Here regarding measles, it's very common in the exam. Measles and scarlet fever, very common in the exam. So you have to be familiar with the features, incubation period, the cause, and also the complication and the treatment. They can ask you any of them. So measles here, as we said, the causative organism, Paramyxoviridae, groups of virus, incubation period 7 to 18 days, average 10 days. It can be an option in the exam. spread by airborne or droplet transmission. It can be option in the exam. The classical presentation, so they can give you scenarios. The patient has high fever, coryzal symptoms, photophobia, conjunctivitis. So conjunctivitis here, it's very common. The rash that associated with widespread erythematous, as we said, maculopapular rash. And here, oblique spots, they can give you options which of the following features, okay, they can ask you about pathognomic for measles, so you can choose oblique spots, okay. Or they can say the patient has white lesions on the buccal mucosa, so what is the pathognomic for measles, so you can choose. Or they can give you image, so you can choose. So here measles is notifiable disease in England and Wales. So they can ask you directly, is it notifiable or not? And also the next action. So the patient already, they can mention like that in the scenario, the patient already diagnosed and the patient treated. What is the next action? So the next action, you have to notify because already treated. So after treatment, you have to notify. Public Health England recommends that children with measles be kept away from school. It can be another question. So you have to keep the patient away from school if he's in school, or nursery if he's younger, or child minder for 4 days. So it can be an option. How many days? So 4 days from the onset of rash. It's very important. Okay. Differential diagnosis. So rubella, rosella infanta, scarlet fever, Kawasaki, erythema infectiosum, enterovirus, infectious mononucleosis. So they can give you this image. And again, when you are searching, when you are studying, you can write in Google measles. They can give you different images. You have to be familiar with different images. And what is this?
Oblique spot.
Okay. Yeah. So diagnosis, how to diagnose, how to confirm here. So they can give you any of them, you can choose. So if you find in the question, salivary swab for measles specific IgM, you can choose. Serum sample for measles specific IgM. Salivary swab for RNA detection, you can choose if you find any of them in the question. Possible complication, here the most common otitis media. It's not serious, but the most common. So if you find, you can choose otitis media. Also febrile convulsion, it's not serious, but it's common. Pneumonia here is serious, but not common. So the most common otitis media, febrile convulsion, and pneumonia, bronchiectasis. So it's a serious but not common. Prophylactic antibiotic. So here shown to reduce incidence of some complications in children in areas with high case fatality rates. So this patient, it can protect from pneumonia, otitis media, and tonsillitis. Okay, so why prophylactic antibiotic, guys? What is the causative organism?
Thalamus.
Yeah, and here prophylactic antibiotics reduce the incidence of some
Secondary infections.
Yes, thank you, guys. Reduce the incidence of some complications like what? Pneumonia, otitis media, tonsillitis. Also, human normal immunoglobulin prevent or reduce severity of an attack in infants under 12 months. So you can use under 12 months. So if you find this option, you have to check the age in the scenario. under 12 months. Also, immunocompromised children, they can ask you clearly, for example, human normal immunoglobulin, when to use. If you find the option under 12 months, you can choose. Immunocompromised children, you can choose. Pregnant patient, if used within 72 hours of exposure. Measles, mumps, and rubella vaccination indicated in healthy, unimmunized, or partially immunized children if used within 72 hours of exposure to measles. So the patient exposed to measles and he is healthy, unimmunized or partially immunized. So you can give him the vaccine, MMR. Vitamin A, reduce mortality and pneumonia specific mortality in children under 2 years. Okay, fifth disease, what is called?
Slap-cheek syndrome.
Yeah, slap-cheek syndrome. They can give you this image or another image. You can search by fifth disease or you can search in Google with slap-cheek syndrome. They can give you different images. So it's a common childhood exantheme caused by parvovirus B19. The clinical features of fifth disease, so they can give you scenario with mild coryzal illness, means the patient has, what are the prodrome, guys, as we said?
Incubation period.
Incubation period.
Irritability, the patient has fever, the patient has lethargy, and so on. Fever. The rash occurs after 3 to 7 days. So the incubation period here, 3 to 7 days. Erythematous rash on cheeks with circummoral pallor. Morbilliform rash appears on the extensor surfaces of the arms, legs, 1 to 4 days after appearance of facial rash. So the rash, 3 to 7 days on the cheek, and regarding the arms and legs, 1 to 4 days after the facial rash. So it will be specific here if they mention that. So the treatment self-limiting in children, but can cause intrauterine infection and hydrops vitalis in pregnant women. So if already pregnant exposed to this, so it can cause intrauterine infection and hydrops vitalis. Also cause transient aplastic crisis. You have to be familiar with that. Therefore, affected children should be kept away from pregnant women and the individuals that are immunocompromised or have hematological conditions. Again, you have to be familiar with different names: fifth disease, erythema infectiosum, slap-cheek syndrome, as you see here. Most commonly occurs in the age 4 to 12 age. In the UK, in April and May. Infectious, the period of infectivity before the rash develop. Any of them can be a question in the exam. The rash itself, painless. It's a clinical diagnosis. It means you can diagnose from the features. So onset of bright red cheeks appear if they have been slapped. What about the treatment? Only symptomatic. Extra care. So if pregnant woman, increased risk of miscarriage in woman exposed to fifth disease. So any pregnant exposed to fifth disease, it's a high risk for miscarriage. Also, you have to make extra care in sickle cell patient, reduced immunity. So it can be a question in the exam. Who needs extra care in fifth disease? So pregnant women, sickle cell patients, and the patients who are immunocompromised. A scarlet fever, it can be a common question in the exam. You have to be familiar with the causative organism, Streptococcus pyogenes, incidence from 2 to 8 years of age, infectious for 2 to 3 weeks after the onset of symptoms. It's very important. Clinical features, they can say in the scenario, the patient has sore throat, fever, headache, fatigue, nausea, vomiting, blanching rash or sandpaper-like, strawberry tongue also, cervical lymphadenopathy, flushed face with marked circummoral pallor, and pathognomic here, Scheimer spots. You have to be familiar with that. So if you diagnose, they can give you this image. This image is very common in the exam. So they can give you also this one, Scheimer spots. The treatment is very important. It can be a question in the exam. So dexamethasone penicillin or penicillin 4 times a day, 14 days. You have to be familiar because sometimes they will give you the name of the medicine and they will give you 4 options or 5 options with different route and dose and the times also. So they can tell you 4 times, they can give you option 5 times or 1 time, 5 days, 10 days. So you have to be familiar with the dose and route and the time. Exclusion, at least 24 hours after starting appropriate antibiotic treatment. Okay, very, very important exclusion. So you have to understand the exclusion. You have to keep the patient away from school or nursery. It's very important. So in scarlet fever, 24 hours after starting appropriate antibiotic treatment. Impetigo, so you have to be familiar with bolus and non-bolus, 2 types of impetigo. So I think this one from the image, it's a non-bolus, and this one from the image, it's bolus. So this one around the mouth and the nose, this one around the pelvis. The management, so if bolus and widespread non-bolus, you can give oral flucloxacillin. We are talking about widespread non-bolus. It can be the same medicine for bolus. But if local non-bolus impetigo, so hydrogen peroxide cream. Why here cream? Because it's local. You cannot use cream for all the body. Okay? So locally here, it's logic to use cream or topical antibiotic. But if bolus or widespread, so you can give oral, it means systemic here, because it's widespread. Chickenpox, so highly infectious disease caused by varicella zoster virus, so it's a DNA virus. The majority of cases mild to moderate, and the infection is usually self-limiting. Serious complications are rare but can occur in immunocompromised patient and comorbidities. Incubation period, it's very important, so 14 to 21 days. And the infectious few days before appearance of rash until around a week after the first region. So all these can be questions. They can ask you about incubation period. They can ask you if infectious or not. They can ask you when to be infectious. So few days before the rash and until 1 week after the first region. Clinical features of chickenpox. So pyrexia, it can be 3 to 5 days. Initial rash macular, and it can develop into papule. So you can say maculopapular. The lesion then become vesicular and later evolve into pustule. So macule, papule, vesicles, pustules. The lesion, itchy, the rash, peak around 48 hours in immunocompetent patients. So the typical distribution here in the face, trunk, and limbs. The vesicles dry and crossed over and can scar if scratched. The patient has headache, malaise, abdominal pain. So they can give you this image in the exam. And here, the most important, and it can be a question in the exam, complication. So complication here in pregnancy, regarding the mother, it can be pneumonia. Also, it can be hepatitis, okay? But the most common, pneumonia. Regarding the fetus, it will be fetal varicella syndrome. So it means skin scarring, eye defects, hypoplasia of limbs, and neurological abnormalities. So what is the treatment? Oh, of course, it's viral, so you can give acyclovir oral, and again in the exams they can give you option for oral, option for IV, so you have to be familiar with those routes. 800 milligram 5 times a day for 7 days. If patient presented with 24 hours of rash onset. Parenteral antiviral treatment, so you can give 7 to 10 days in immunocompromised patient and severe cardiovascular or respiratory disease or chronic skin disorder. That's why when you are studying, guys, study for the exam, not memorizing. So if they give you patient immunocompromised, or they mention in the scenario the patient has cardiovascular or respiratory disease or chronic skin disorder, you will choose oral or parenteral?
Parenteral.
And 7 to 10 days?
7 to 10
10 days.
Yes, this is how to study. While most cases are relatively mild, if serious complications such as pneumonia, encephalitis, or dehydration, the patient should be referred for admission. So they can ask you different questions regarding admission, indications of admission. So one of them, pneumonia, encephalitis, and dehydration. Okay, regarding chickenpox, you have to be familiar with shingles. Okay, so the same here, varicella zoster virus, but here it can become dormant in the nerve. So the patient already doesn't have chickenpox now, and after how many years stay in the nerve cell bodies, and after that it can be reactivated later. Okay, and it's unilateral or bilateral dermatome, guys?
Unilateral.
Unilateral. It's a vesicular and painful rash. Okay, so you have to find that in the scenario. Patient may have several episodes. So, for example, he has same episode last year or something like that. Okay, it can be reactivated by stress or immunosuppression also. If presenting within 72 hours of the rash appearing, you can give oral acyclovir. It can shorten the duration of illness. Shingles, as we said, varicella zoster virus. Okay. So here, it can follow any nerve, like trigeminal. Okay. What are the triggers? Why this patient has shingles again? So maybe advancing age, more than 50 years, immunosuppressive illness, physical trauma, or psychological stress. Okay, so the most common site, it can be a question in the exam, is
thoracic.
yeah. The second most common is
ophthalmic division.
ophthalmic division. So the most common thoracic, the second common is ophthalmic division. Okay. So this one, what is the diagnosis?
Shingles.
Shingles involving thoracic
And
dorsal ganglion. Yes.
and this if here,
Ophthalmic
division.
yeah,
Of
any image in the exam involving the the yellow color, so it's ophthalmic division. So shingles, ophthalmic division. In the red area,
Maxillary division.
maxillary
Of
division. Okay, and the brown one,
mandibular division.
Mandibular.
mandibular division. So it's a shingles also. So this one,
Ophthalmic division.
Maxillary divisions. And
Mandibular.
Mandibular.
okay. So the management, as we said, oral antiviral treatment within 72 hours of rash onset. And of course, pain management because it's painful. Okay, eczema. So the most common type of eczema and the most important in the exam, atopic eczema. You have different types of eczema, but they can ask you regarding atopic eczema. So it's the most common form of eczema, cause skin to become itchy, dry, cracked, and so on. And the patient has history of allergy also. So the main symptom of eczema, as we said, itchy, dry, flaky, inflamed, irritated skin. Other symptoms, it can be intense itching, red or brownish gray patches, small raised bumps that ooze fluid when scratched, crusty patches of dried yellowish ooze. Second, scaly skin, scratching eczema further irritates and inflames the skin. So this can cause infection and must be treated with antibiotic. Here, regarding the causes of eczema in general, it can be triggered by overactive immune system. So what is the mechanism? What is the pathophysiology here? Eczema sometimes caused by abnormal response to proteins that are part of the body. How? You have to understand the normal mechanism first. The immune system ignores proteins that are part of the human body. So all of our bodies, we have proteins normal in our bodies, and our immune system not attack these proteins because it's our body. But here what happened? The immune system by mistake attack the protein of our body. That's why it's called eczema. Okay, so flare up, it means a chemical. So all people who have eczema, maybe because of chemical. Also, rough scratchy material, synthetic fabrics, raised body temperature, sweating, temperature change, whatever hot or cold, sudden drop in humidity, stress, food allergies, animal dander, or respiratory infection. So again, the most common is atopic eczema. The diagnosis, how to diagnose in the exam, they will mention, for example, itchy skin condition in the last 12 months and 3 or more of the following. So visibly irritated red skin, increases of skin, like cheeks, elbows, front of the knees, in children age 18 months or under. History of skin irritation occurring in the same areas mentioned above. Generally dry skin in the last 12 months. Again, history of asthma or high fever. So if you find in the scenario asthma or high fever, so it's supporting the diagnosis. Children under 4 must have immediate relatives such as parent, brother, or sister who has one of these conditions. So also family history. The condition started before the age of 2. This doesn't apply to children under the age of 4. NICE guidelines recommend using flucloxacillin first line treatment. So it can be an option in the exam. If they give you a diagnosis of eczema, sometimes they will not mention the diagnosis of eczema. You will understand it's already eczema, and they will ask you what is the first line treatment. So you can choose flucloxacillin. Most commonly caused by staphylococcus and or streptococcus. It can be an option in the exam. Swab should only be taken if antibiotic resistance is considered likely or different pathogen is suspected. It can be an option in the exam. Erythromycin used in those allergic to flucloxacillin. So if they mention the patient is allergic to flucloxacillin, so you can choose erythromycin. Clarithromycin in those who cannot tolerate erythromycin. So you have the first option, flucloxacillin, if allergic, so erythromycin. If the patient cannot tolerate erythromycin, you can use clarithromycin. Eczema herpeticum. So when patient has atopic eczema and come into contact with herpes simplex. So this is the definition of eczema herpeticum. So here, antiviral treatment can shorten the duration. And this is the image. Some hospital admission indicated for intravenous antiviral. Okay, condition number 4, erythroderma. So it's a term used to describe erythema affecting more than 90% of the body surface. So how to diagnose erythroderma regarding the body surface area? It can cover most of the body. So it's called erythroderma. Also, it can be called exfoliative erythroderma. Also, it can be red man syndrome, different names. So the clinical features, erythema here more than 90%, scaling on days 2 to 6. Keratoderma develops on the palms and the soles. After several weeks, erythroderma and the scaling of the scalp can lead to hair loss. The nails become thickened. Lymphadenopathy also you can find in this scenario. The patient may become systemically compromised. So in general, the causes of exfoliative means scaling. So erythroderma means more than 90%. You can find eczema, psoriasis, lymphoma, leukemia. Okay. Also, one of the causes like drugs, sulfonamide, isoniazid, penicillin, all of them can be a question in the exam. So what is the diagnosis here, guys?
Erythroderma. Erythroderma.
Yeah, or red man. So possible resultant, it can be a question in the exam, maybe infection, maybe withdrawal of corticosteroids, the patient stopped steroids, hypocalcemia, use of a strong cold tar preparation. Complication here, as you see, the patient has more than 90%, so it can cause dehydration. The skin will be broken. That's why the patient can get dehydration, hypothermia, cardiac failure, secondary infection, protein loss edema, also anemia. So you can expect, it's logic to expect this complication. So the management here refer to medical team and the dermatology for admission. So this patient needs admission. Keep the patient warm because of hypothermia and the dehydration. Start IV fluid. Emollients because dryness. Apply with dressing. IV antibiotic because of more than 90%. Number 5, infections of skin and soft tissue. So you can expect like psoriasis versicolor or tinea versicolor. It's a common skin condition. What is the causative organism, guys?
LSEZF
And the globosa. Presentation is with multiple patches of altered pigmentation, usually on the trunk. In fair skin individual, these patches are usually hyperpigmented. So it will be opposite of the patient. If the patient is white, it will be black or dark. If the patient is dark, it will be whiter. Okay? Treatment here, antifungal. So you have to be familiar with the causative organism. You have to be familiar with the treatment. Antifungal, like ketoconazole shampoo or Nizoral. Methicillin-resistant Staphylococcus aureus, it's called MRSA. So it's not common. Before it was common. So MRSA here means resistance. So resistance is caused by position of MICA gene, which codes for low affinity penicillin binding protein, usually sensitive to teicoplanin, vancomycin, daptomycin, benzoyl. Also, you can use intravenous ibuprofen. You have to be familiar with cellulitis and erysipelas. What is the difference between cellulitis and erysipelas? So it depends on the involvement of the layers of the skin. Okay, so areas of skin erythema, edema, and worms, they develop as a result of bacterial entry via breaches in the skin barrier. So both of them, it's bacteria. Erysipelas, infection of the dermis and the upper subcutaneous tissue. So this is the difference between erysipelas and cellulitis. Erysipelas here, it's infection of the dermis and the upper subcutaneous tissue caused by Streptococcus pyogenes. Okay. It can also more rarely be caused by beta hemolytic streptococci or staphylococci. Patient systemically unwell with fever and rigors is common. The infected area is red, hot, tender. Local edema produce raised, well-defined edge, enable it to be distinguished from cellulitis clinically. So you can differentiate between them in the exam if they will give you the image, and you can differentiate if they mention in the scenario regarding raised, demarcated, and so on. Cellulitis here involves the deeper dermis, so it's deep, and the subcutaneous fat. Erysipelas, the upper dermis, so the difference between cellulitis and erysipelas. Erysipelas here superficial, cellulitis it's deeper. Abscess. Abscess here, collection of pus in the dermis and subcutaneous tissue. So you have to be familiar with erysipelas, cellulitis, and the abscess. So the cause here, erysipelas caused by strep pyogenes, and cellulitis caused by streptopyogenes and rarely Staph aureus. Regarding involvement, erysipelas, the upper subcutaneous tissue and lymphatic vessels. Here, cellulitis involve deeper subcutaneous tissue. Regarding history, erysipelas history antecedent throat infection, and also here in cellulitis, deeper fissures. Common site you can expect in face with bridge of nose and the cheeks, but cellulitis you can expect in legs. It's very common in the leg. Well-defined margins, but here in cellulitis, not defined. Vesicle or bulla formation. Here in cellulitis, bulla formation, but in severe. If late stage, in cellulitis, late stage, okay, and complicated. Here, erysipelas, it's self-limiting. In cellulitis, if untreated, it will cause necrosis. Okay. Regarding staph, you have to be familiar regarding staph organism. It can cause impetigo, eczema, folliculitis, bronchiolitis, carbuncle, cellulitis. If direct infection of a skin and the adjacent tissue. So here, it will help you in the exam if they ask you what is the causative organism of impetigo. So you can think about staph, okay, folliculitis, and anything like that. It can be secondary infection, like in eczema, infestation, ulcers. Because of the toxin of staph, it can cause SSSS, scalded syndrome, or toxic syndrome, staphylococcal, it means scarlet fever, also recurrent perennial raceme. So here they can ask you in the exam the mode of infection. So here it's a direct infection through skin and the adjacent tissue. It means the skin is broken already. Okay, and the secondary infection. So if you find this option, you can choose in eczema or ulcer or infestation. If you find here in a scalded syndrome, so it's because of effect of toxins. It can be option in the exam, so you can choose toxic shock syndrome. So if you find, you can choose because of toxin. Okay, a scarlet fever also, it can be because of toxin of a staph. So this image, it can show you the difference between cellulitis, it's deeper. So the dermis, epidermis, dermis, and subcutaneous tissue. And here, erysipelas can affect the epidermis and the superficial area of dermis. Here, the abscess, as you see, it's palpable here. What is the diagnosis here, guys?
Cellulitis.
Okay. So you have 4 classification in cellulitis. So class 1, 2, 3, 4, you have to be familiar with them because they will not ask you regarding memorization. But for example, if you find a scenario with systemic problem, for example, the patient has shock, so you can choose class 3. So anyway, according to the classification, you can manage the patient. So class 1, it means high dose oral flucloxacillin, 500 to 1000 milligram 4 times daily for 5 to 7 days. Other classes, so it will be IV flucloxacillin 4 times a day. Okay, so here you have to be familiar with it. The most important flucloxacillin in any cellulitis. But again, sometimes they will give you options similar to each other. So you have to be familiar with that. What is the diagnosis here, guys?
Necrotizing.
Okay. Shared.
Yeah, it can be a question in the exam. They can give you the image and they can ask you what is the treatment. What is the treatment?
Surgical debridement.
Debridement. Amputation.
Okay, so treatment here, surgical debridement, antibiotic. Okay, for you as emergency physicians, the most important for you, antibiotic and refer for surgical debridement. Condition number 8, Line purpura. So they can ask you about the pathophysiology. So it's a type 3 immunocomplex mediated hypersensitivity reaction. Okay. 1 second, guys. Okay, so here they can ask you regarding the pathophysiology. So IgA is deposited in vasculitic skin lesions and in the kidney. 1/3 of patients has history of atopy and many patients have a history of recent throat infection. The most important here is the clinical features. They can mention in the scenario maculopapular rash, urticaria, also nephritis, testicular inflammation, sinus involvement. Okay, like the patient has seizures. But here, the most important, the image. They can give you this image or different image. You can search in Google regarding images and the complication. So they can mention this in the scenario. For example, the patient has abdominal pain or the patient has intussusception, or maybe the patient has testicular torsion, the patient has nephritic or nephrotic syndrome. Any of them can be in the scenario. The patient has AKI, acute kidney injury, the patient has seizure. So it can be features in the scenario, so you can choose Line purpura, or they can ask you the opposite way. The patient has diagnosed by Line purpura, which of the following complication you can expect or it can support the diagnosis. So you can choose any one of them if you find. Again, the most important here, intussusception and AKI, acute kidney injury. And this is the image. Stevens-Johnson syndrome, as we said before, erythema multiforme. So the patient has in the start erythema multiforme. Which lesion, guys, for erythema multiforme?
Target lesion.
Target
lesion.
Target lesion, okay. So the early stage will be target lesion. After that, it will be Stevens-Johnson syndrome. And if increased body surface area, what is called?
toxic epidermal necrolysis.
Yeah. So what is the difference between them? As we said, this one less than 10% and this one greater than 30%. Okay. And here is the same causes or same precipitants. It will be the same, whatever target, erythema multiforme or Stevens-Johnson syndrome or toxic epidermal necrolysis. So we are talking about the same. The difference, as we said, early stage or late stage, and also body surface area. So you have to be familiar with the drugs, tetracycline, penicillin, vancomycin, sulfonamide, non-steroidal barbiturates. So What is that, guys?
Steven Johnson.
Steven.
You have to check the body surface area, right?
Right.
Yeah, you have to check the body surface area. And the involvement here of mucous membrane. Number 10, toxic epidermal necrolysis, the same issue, as we said, same drugs, and here's the difference in involvement, and as we said, it's a potentially fatal form of erythema multiforme. So the difference here regarding first one, Stevens-Johnson syndrome, and this one is toxic epidermal necrolysis, but the difference is the surface. So this one less than 10%, this one more than 30%. And between them, it's called overlapping. Okay, we finished, guys, today. Please be active. Which skin condition is not correctly paired with its associated systemic illness? The patient here, 54 skin condition has occurred secondary to systemic illness that has suffered from.
Last one, vitiligo.
Option E, vitiligo and Cushing disease.
Okay,
أيوة vitiligo Cushing.
so what is the answer? Why vitiligo and Cushing's disease?
vitiligo مو مع
Was
الأديسون.
Edison. Was Edison.
In Cushing hyperpigmentation.
Stress.
What is the single least likely cause of this condition?
Diabetes insipidus. B.
Diabetes insipidus, second one.
So here I can choose nigricans.
Yeah.
So diabetes insipidus. Okay, you can find in obesity, lymphoma, polycystic ovarian syndrome, gastric carcinoma. Okay.
Psychosis sarcoma. A.
Okay. Because
HIV patient.
okay, so HIV, so it's confirming. Okay, single most likely causative organism.
Streptococcus.
You have to check. So Streptococcus pyogenes. What is the diagnosis here?
Erysipelas.
Excellent. Single most likely diagnosis? Erysipelas. Okay. Single most likely diagnosis? I did not show the image. Okay, why is this one measles, guys?
Measles because of the
الفورمال
Photophobia behind the ears.
High fever.
أيوة
Coryza symptoms. Conjunctivitis.
Number one, the
Photophobia.
age. The age, child, okay? And also rash fever that have been present in the past 3 days. It means a prodroma, right?
Right.
it started behind his
Yeah,
ear.
behind the ear and spread to his face body. Coryza symptoms, it means prodroma also. Dry cough, conjunctivitis, okay? And the photophobia. All are confirming. Okay. Of course, if you see the image, it will confirm more. Single most likely diagnosis.
Measles.
Measles.
Coptic spots.
Measles. Complete spots.
Okay.
Measles.
Okay. Which of the following is indication for parenteral acyclovir?
Immunocompromised.
Compromise.
Option A.
Okay. Otherwise, you will give oral.
Oral.
Yeah.
Okay.
800 milligram.
Single most likely diagnosis.
Painful rash.
الرش
Herpes zoster could be herpes zoster. Unilateral rash. Unilateral rash.
Shingles.
Herpes zoster.
Herpes zoster. Okay. Single most likely diagnosis.
Chicken pox.
chicken box
Chicken pox 10 years old with
شيء rash.
Itchy rash. Chicken pox.
Yes. Chicken box.
Chicken.
Excellent. Chicken pox. Okay. Indication for consideration: use of oral acyclovir in this patient.
Last option. Patient age 18 years.
patient aged 18 years.
Okay. Usual incubation period for diagnosis in this case: the patient 10 years,
14 to 20.
fever, headache.
31, 14 to 21. Chickenpox.
Option C.
Okay.
14, 20. Yeah. Chicken box.
Single most likely diagnosis.
The patient who
SLE. Option A.
SLE. Systemic lupus erythematosus peristome.
SLE.
SLE.
Okay. Most common site of reactivation of varicella zoster virus in a
Thoracic nerve.
Option C. Thoracic nerve.
Okay. Most likely diagnosis.
Single.
Single.
Sheikh is
Ophthalmic division of the trigeminal nerve.
Division of trigeminal nerve.
Okay. Most likely diagnosis.
Maxillary division of trigeminal
Maxillary
nerve.
division of trigeminal.
Okay. Most likely diagnosis.
Mandibular.
Mandibular region of
Mandibular division of trigeminal.
Okay. Which of the following indication for parental acyclovir?
Chronic skin disorder. Option A. Option A.
Okay. Most appropriate way to confirm diagnosis of shingles?
history and examination alone.
X-ray and examination.
Option D. History and examination.
It means it's a clinical diagnosis.
Diagnosis.
Yes.
Okay. Single most likely diagnosis.
Eczema herpeticum. Option D.
Eczema herpeticum. Young
Why?
with history of eczema before.
History of eczema. And
هو فيرا أيوة.
Vaccination.
And the patient feverish.
Number 4.
Chance of infection and history of eczema. Eczema herpeticum.
تراش يجيجوا. Beside of the mouse, yes.
Most likely responsible for this rash.
herpes simplex. Option A.
What is the diagnosis?
Erythema multiforme ولا شنو؟
Erythema multiforme.
Multiform. Yes.
Yeah, erythema multiforme. What is the lesion?
Target lesion.
Target lesion.
So herpes simplex virus, we have two types, type A and type 1, type 2. Which type?
Type
Type
1.
1.
Type
Type
1 is
1.
the commonest.
Okay.
Single.
Most likely diagnosis?
Erythema multiform.
Okay.
Erythema multiforme.
Multiforme. Yes.
Single most likely diagnosis?
Erythema abignei. Option B. Because of chronic pain
Option B,
history.
chronic abdominal pain.
So it's hot.
أبي اللي هي الهوت ووتر.
Okay.
Yes.
Okay. First line investigation to confirm the diagnosis.
تمام.
Option D, I think.
For direct immunity.
Option D.
What is the
Yes.
diagnosis?
Pemphigus, bullous pemphigus.
Bullous.
Pemphigus bullous.
Skin biopsy.
Skin biopsy for
biopsy,
direct
yeah.
methods. Yes.
Okay, you have to take a skin biopsy. Which of the following most appropriate first line treatment?
Corticosteroid, option C.
Pemphigus vulgaris.
Oral corticosteroid.
Option C.
The treatment is
Oral
Okay.
corticosteroid.
So, oral corticosteroid. Single treatment regarding this condition, slapped cheek syndrome.
Ricina infecciosa.
Maybe it is
Disease.
Option D. It is also known as Rithema infectiosa.
Ricina infecciosa infectious disease.
هي الإريثيما not infectious صح؟
Ricina infecciosa means 50 disease. Other
So you
names,
have, you, have, you have to be familiar with different names.
Different names, yes.
Single most likely diagnosis.
meningococcal
Meningococcal septicemia.
Meningococcal
meningococcal septicemia.
Yeah. So this Berbera or Petechia or ecchymosis?
Berbera.
Berbera.
So meningococcal septicemia, the patient is in shock. So headache, neck stiffness, photophobia, it's signs of meningitis, but because of shock here, the patient has fever and shock, so it's meningococcal septicemia. Most likely causative organism, 5 years, sore throat, loss of appetite, itchy spots on the palms for hand, soles. To examine.
Oxaci A. Pemphigus.
Hand foot mouth disease.
Okay. Single most likely diagnosis. Erythematous morbilliform rash.
Option D. Fifth disease.
Fifth disease.
Okay. Single organism. Here, placenta. IV drug user.
Bacillus anthracis. Option C.
Bacillus anthracis.
Okay. Single organism responsible. Most appropriate management option. Seven years. Eczema. Flare up hair symptoms.
Topical corticosteroid.
Corticosteroid.
Flucloxacillin.
Corticosteroid.
Option
B.
MB.
Option B.
okay.
MB.
Which rash is this most likely to be? Painful rash.
Nodosum. Erythema nodosum. Option A.
So this one. Okay. They said here bilateral hilar lymphadenopathy. So what is the diagnosis?
Scardiosis.
Cardiosis.
Another name?
Burn syndrome.
Another name?
اسمها كده.
Lofgren syndrome.
Okay.
Yeah.
Single most likely diagnosis.
35%.
Option E, toxic epidermal necrolysis.
More than 30%.
Because the rate here.
35. Yeah.
35%.
30%, more than 30%.
So if early stage, it will be erythema multiforme. If late stage, you have to check the body surface area.
Percentage, yes.
If less than 10, it will be.
Steven Johnson.
If more than 30, toxic.
Toxic epidermal.
Following statement regarding Steven Johnson syndrome is false.
Option A.
First one.
First one.
Less than 10%, not more than 10%. First one.
Okay. So what is the diagnosis here?
Psoriasis, acute pustular psoriasis.
Pustular psoriasis.
Okay, acute pustular psoriasis. Excellent. Which of the following statement regarding Steven Johnson syndrome is true?
Option B.
Second one.
Second one.
Second option.
10%.
10%.
Okay. It's false.
Option A.
Option A.
Repeated.
Greater than 30.
Not repeated, but they change it true and false.
Yep.
Which skin rash initially present in this patient?
Erythema multiforme. Option E.
Same multiform.
Option E.
Why?
Target lesion.
Erythema multiforme. Mucous membrane and fold.
Mucous membrane وفي target lesion.
We have three options. We have erythema multiforme, we have also Steven Johnson syndrome, we have toxic syndrome, right?
Yes.
But we have only here erythema multiforme.
Because they are showing only the tongue and the
Question
Yeah.
also asking about initially.
and only
at the
8%.
beginning.
And it's only 8% total body temperature.
Less than 10 Steven Johnson.
Yeah.
قال affecting 8% of a total
Yeah,
body.
8%, but we don't have Steven Johnson here.
Yeah.
Because it's showing tolding its initial presentation. Initial
Yeah.
presentation in this case is erythema multiforme.
Early stage.
Yes.
Single most likely diagnosis.
Steven Johnson.
Steven Johnson.
Johnson syndrome.
Yeah, why is Steven Johnson here?
Less than 10, 8%.
Less than
Yeah.
10%.
Because he said has now progressed to severe. It means it's a late stage. Single most likely diagnosis.
Abdominal pain, psoriasis, and ganglion pain.
Option B. Second one.
Option
Inoxinal in purpura.
Yes, henoxinol.
Okay.
Yes.
But you have to check the scenario because you have differential diagnosis meningococcal meningitis. Okay.
Yes. Yes.
Yes.
So
Patient is stable.
the patient is good or not.
Yes, position of the child also. If the child is sitting,
It's you mean position of the patient. It means you mean the patient
it
is
gives
well.
an idea. Yes.
Yeah,
No
excellent. Because if the patient is unwell, he will be
Lying down. Yes.
and they may be unconscious. But this patient, it means conscious.
Yes, correct.
Yes. Also, no fever or no neck stiffness. Nothing.
Yeah. And also recently had sore throat. Okay. Which organism associated with this condition?
Zelenia.
Malassezia.
Option D, Malassezia furfur could be.
Malassezia furfur.
Yes.
This is tinea versicolor.
Okay, so what is the diagnosis?
Tinea versicolor.
Tinea versicolor.
Okay. Okay. MERS.
Option C, imipena.
Okay.
Vancomycin.
Most appropriate treatment?
Ketoconazole shampoo. Option A.
Ketoconazole, correct.
Okay, so what is the diagnosis?
Tinea versicolor.
Tinea versicolor.
Single most likely underlying cause? Exfoliative erythroderma.
ريدمان سندروم هو الريستوديرما. عايزين شنو عايزين underlying cause.
Atopic dermatitis.
Psoriasis. Option D.
Atopic dermatitis. Thank you, guys.
Thank you, Dr. Hani.
Thank you, Dr. Hani.
جزاكم الله خير.
Thank you.